Philippe is going to be talking about a study that he designed and led for many years called the FIPOS study. It's a first episode outcome study. And the title of his talk is, Can we predict good outcome among patients who refuse medication? So over to you, Philippe.
Hi everyone. It seems to be working, but we hope it does work actually. Okay, so thank you, Brian, to have organized this symposium. I'm going to talk about some data we have on how to identify patients with first episode who could maybe do well without medication. So as you know, the current guidelines for the treatment of first episode suggest that you should give antipsychotic medication. Medication is when you have sustained full threshold positive symptoms, and current guidelines propose 12 months of antipsychotic treatment after the first episode and 24 months after the first relapse. Guidelines also suggest you should use atypical antipsychotics and use obviously the low dose strategy. So that's the guidelines based on the data we have. I'm going to discuss what we have to support these data so far, but there's still a big question: do all patients need antipsychotic medication? And all of us have seen patients who actually refuse medication and nevertheless do well, and it's been a big issue for many years. One of the most vocal person about this issue is John Bola, actually, who studied a lot this issue. And one of the papers he published in 2012 was about what do we have, what is the basis, the research basis on which we base the fact that we have to give medication to first episode psychosis patients. Actually, there's not much data to support that. It doesn't mean it's not true, but there's not much evidence that has been studied and published to support that. So he looked into that. Actually, this was in 2012. Might have changed, but actually he found that only 6 trials really did a randomized controlled trial, and this was on a total of 623 patients. And on this basis, we decided we have to give medication to all patients. So he was criticizing this very much. And actually, in the studies that he looked at, giving antipsychotic medication increased adherence to global treatment. So the patients dropped off less in the arm receiving medication than in the arm who didn't receive medication. But obviously, there was much more side effects in this group of patients. So he questioned, is it worth it? And his conclusion was that actually we don't have enough data to really say that every patient needs medication. And he suggested that we should do more research, and that's what we will be talking about today. Also, he looked into the harm happening to patients to whom you don't give medication. Some groups have tried to withhold medication for a while and follow patients and give intensive psychosocial treatment and then see what happens. And actually, if you look at in the long term, there's not always much difference between patients. So also he said, well, maybe it's not bad to try to look more into can we treat subgroup patients without medication. The incentive to question this issue is that, as you know, typical antipsychotic have side effects. This is not to be discussed, but atypical antipsychotic as well. As you know, metabolic syndrome, diabetes, cardiac arrhythmia. So there's a lot of side effects in some benign treatment. We also don't know if antipsychotic might be harming the brain. We don't know either if not giving medication would harm the brain. So I mean, it's a complicated issue. But there's some voices saying, well, that medication is not that harmful also to the brain. So that's another incentive to study the issue. It's also an issue of growing relevance because we have seen this morning, there's a lot of places where early intervention programs are organized, and as we know, the duration of untreated psychosis has diminished, so we get patients much earlier, maybe with more attenuated symptoms, so less intense illness, and maybe, and we have developed also a lot of psychological interventions, so there's a lot of new tools that we could use, and with this evolution, and having patients earlier, maybe we can again revisit this issue. So, but the important question is, can we identify the patients who do well and the ones who really need medication? And that's still an unsolved issue. There's some data on that. An old study from Langfeld who found that some individuals have good outcome, and he found some of the characteristics of these patients, mostly affective psychosis, acute onset, absence of schizoid features, and presence of a precipitating cause. So this was a profile, he said, that would respond better without specific intensive treatment, that they would have a better outcome than the others. Then Bola and Moshe, in a study they conducted in 2002, delayed in introduction of antipsychotic in a limited number of patients, and found also a profile of patients who would do well, fewer diagnostic symptoms of schizophrenia, older age, and higher functional level. So, but there's not much data on that, but that's a bit of data. And they also estimated the number of patients who could do well was between 10 and 40%. Maybe that's a bit optimistic. But Dixon 95 and also 25%. So there's a consistent group of patients who might do well without this kind of treatment. So I'm going to talk about some data that we had. We wanted to look at this issue in the v002 study. So it's a study we did with Martin Lambert quite a while ago, looking at 704 files of patients treated at EPIC between 98 and 2000, and we looked into the files in very minute details. But that's a file audit study, so it's not face-to-face interview and all that. And we found that adherence to medications, full adherence, was present in 35% of patients. 47% of patients had various number of phases of not taking the medication over the 18 months. But 18% of patients actually never were exposed for consistent time to antipsychotic medication over the 18 months, despite all the effort put in trying to motivate them to do so. And we published a paper comparing the ones who adhered to medication to the ones who didn't adhere to medication, and found actually that the ones who took the medication as a group did better than the ones who didn't take medication. But then we thought, okay, but what happened to the 18% of patients? Did all of them have poor outcome? As a group, they functioned lower than the other ones. But as a group, can we find some patients in this group who do well? And that's the data I present now in the last few studies. So we wanted to know, within these 18% of patients, how many have favorable symptomatic outcome, functional outcome, and what would be the predictors of having a good outcome despite not taking medication. So that's the flow chart. 704 patients. We had to exclude a few because of diagnostic being non-psychotic disorder, missing data and all that. So we had actually 108 medication refusers patients. So the first paper I talked to you about was the one where we compared the one who adhered to medication and the one who didn't. And what I'm talking about now is comparing the ones with poor and good outcome. And that's the characteristic of this subgroup of refusers, just to show you which type of, and show you that these patients were quite ill, so it's not a soft type of psychosis. So 22 years of age, majority of male, just like in EPIC, but even more male in the medication refusers. Many of them had been exposed to trauma, and many of them also had used substances before entering to EPIC. They had level on the CGI 5.5 on average, so it's quite high in terms of intensity of illness at the entry to EPIC, and a low level of functioning, 32 on average. So it's real first episode psychosis patients. And so we looked into these patients, and we found that actually 41%, so it's not a small number, had actually good symptomatic remission after 18 months, which means CGI, BP, both sides below 3, so it's really reduction of symptoms basically. And functional recovery was defined as a bit rough, but in terms of having regular work or study activity and independent living, so not living in sheltered accommodation. So this was the definition. According to this, 41% of patients had symptomatic remission, and a third, 33%, functional recovery. So again, this is a poorer outcome than the ones who took medication very significantly. but some patients can recover, and it's not a small number, it's actually an important number. And in terms of predictors of this positive outcome was for symptomatic remission having a better premorbid gap, also number of years of education, and being employed or studying at baseline. So basically it seems to have good symptomatic outcome. It seems to be patients who were not perturbed during their youth, and they could sort of construct life, and then the onset of the episode came a bit after. In terms of functional recovery, duration of prodrome, which is a bit proxy of that as well. I mean, it's patients who had a short duration of prodrome, so not a long time of disruption before developing the disorder. Patients who had lower severity at entry. Being employed or studying at baseline was also a factor predicting good functional outcome. And also comorbidity of cannabis abuse. I mean, the patients who were using cannabis a lot at baseline had a lot of trouble. It's been shown many times that it's really a factor of poor outcome. So, I mean, there's obvious limitations to these data. It's a file audit. It's a biased sample because the patient self-selected to not taking medication, so it's not a randomized controlled trial. Nevertheless, it's a representative sample of patients who didn't take medication and did well. There's also differences between the two groups, so we cannot control for all that, but it gives, this was a hypothesis, we were looking for hypotheses and some lines, ideas on how to identify these patients. Also, the outcome was assessed a bit roughly, but we should do now more prospective studies. In conclusion, good symptoms and functional research is possible in first episode patients without antipsychotic medication. Some characteristics can be identified. So better premorbid adjustment, shorter duration of illness, or a swifter onset, so and lower rate of comorbidity, and these patients might respond well. But again, as a group, patients do better if they receive medication. So until we have done some research, and my colleagues are going to speak about projects, they have to do this research prospectively. We cannot say that we can go on this very thin basis, but there's hope to develop different strategies. But at the time now, I think we still need to go by the guidelines and give medication in a low-dose strategy to first episode patients. Thank you for your attention. I'm not sure there's a microphone for questions, so I think everything was very clear. I don't see any microphones. Sure. Yeah. Yes. He's coming with the microphone. So sorry, I got most of it. He's arriving. Sorry, didn't see him before.
That's better. So my point is that it's very difficult to explore this in a randomized way. So I think, and you have all sorts of biases if you randomize people. So looking at these bigger naturalistic samples is one of the best ways you can best explore this. We've got a poster on it tomorrow that's looking at a slightly later stage, but I think this is where we're going to get some of the answers from.
Okay, yeah, I think Brian and Sean are going to speak about that exactly. How to not bias the sample. I mean, in my study, it's really biased totally because it's self-referred to one arm or the other. But this was just to look into some data and seeing if there's a signal of patients who might do well. That's all. But I understand what you say. I mean, if you randomize, you have to control. You cannot randomize anyone because suicidal patients, you have to treat them. So it's really hard to have a real randomized control trial. You're right. But I think you're going to speak about the inclusion criteria in your study and the strategy that tries to go around that. Yes.
Not something more neutral.
Yes, it's yeah, refuses is probably bad. we had non-adherent, we had non-compliant, we had all of that. But if you have a suggestion, I'm happy to take it. It's they refused medication. Well, not. I don't know if you have something to propose. Okay. Thank you.
One of our psychiatrists in EPIC in Melbourne used to refer to patients as treatment reluctant. I don't know if that's slightly more acceptable, but just any patient that really want to have treatment. But anyway, just moving on. I think that the previous question does touch on something that the next two presentations will focus on, and they're going to be talking about the stages study, which has been carried out in Oregon. And the lead investigator is Dr. Shona Francie. Shona's been involved with EPIC since right at the beginning, and is a very, very experienced person and researcher and clinician in our service. And so she's going to be talking about the stages trial.
This paper has the title of the study, which is a very cumbersome title, I apologise for, but it is actually descriptive. So we're talking about a randomised placebo-controlled trial of intensive psychosocial treatment plus or minus antipsychotic medication for first episode psychosis with low risk of self-harm or aggression. And then we go for the smaller title, the stages study, which a colleague of ours, Michael Burke, invented when we started the study a long time ago now. So we actually started the study some years ago, which goes some way to talk about how difficult it is to recruit young people into the study. Excuse me. This is a better title, I think. Antipsychotic medication, first episode psychosis, an RCT to assess the risk-benefit ratio. So as I said, the study's been going for a long time now. It's got a lot of people involved with it, and I'd just like to acknowledge all of the co-chief investigators, of which Pat is one, and Barnaby, Brian as well, Kelly, Mario are here as well, and then there's a whole lot of associate investigators, very important research staff, but it's also important to acknowledge the clinical staff. Because we've been running for 8 years, we've had a number of case managers and psychiatrists, psychiatry registrars who've been really important in getting this study going over all that time. Not going forward. I'm having a problem. Okay, so just a quick overview of the talk. I'm going to present the background and rationale to the study, the aims of the study, the hypotheses, the methods and the interventions, and then some really quick data that's a description of the cohort, because the study is still underway. We haven't finished recruitment. We're hoping to finish recruitment at the end of this year. So we have 88 young people into the trial to date, and we're hoping to get to 95 by the end of the year. And then Brian is going to talk about some safety aspects of the study. So Philippe's given a good introduction to some of this already. We know that successful early intervention programs mean that we're seeing young people very early in the course of their psychotic illness. We know that there's very strong evidence for the effectiveness of antipsychotic medication in the treatment of acute psychosis. But we also know that the success of early intervention means that we're seeing a more heterogeneous group, that the psychotic symptoms that people have are not always distressing or a primary concern when they're coming in. We know that antipsychotic medications are not recommended in the UHR group, the ultra-high risk of psychosis. And in fact, the line is somewhat arbitrary. So if you use something like the CALMs and you have auditory hallucinations 3 times a week, your UHR, but if you have them 4 times a week, your first episode of psychosis. So it's at a point at which we want to decide whether or not to give antipsychotic medication. We know that the staging model suggests that more benign treatment should be tried in the first instance, and to save the more powerful treatments for later on when the illness progresses or persists. We also know that antipsychotic medications have very significant side effects. We've got emerging evidence that antipsychotic medication is associated with poorer functioning in some of the studies. And we know, as Philip has said also, that there's, in his paper, there's a significant level of non-compliance in first episode samples with antipsychotic treatment. But we also know that a significant number get better. So as Philip has said, some people do get better without using antipsychotic medication. We've also got a growing and significant body of evidence of the effectiveness of psychosocial intervention in the treatment of first episode psychosis. Philip also talked about some of the research around that says that it's not harmful to delay antipsychotic medications for short periods in schizophrenia samples and other psychosis samples. And we know that medication-free research in psychosis can be conducted ethically where informed consent is being given. So the question is the immediate use of antipsychotic medication required in all cases of first episode psychosis? Do we have the threshold correct? So this means it's time to re-evaluate the role of antipsychotic medication in the treatment of first episode psychosis using an RCT. So the aim is to clarify the full range of risk-benefit issues in the use of antipsychotic medication in first episode psychosis. It's an RCT to investigate the effects of providing intensive psychosocial intervention while withholding antipsychotic medication for up to 6 months. So we're going to be looking at functional outcomes, remission rates, brain structures, physical health parameters. And really we're examining the effect of prolonging DUP for a short period of time. Our primary hypothesis is that the group that received placebo will be no worse on measure of functioning, the SOFAS, at 6 months than those that received the antipsychotic medication. We also have a second primary hypothesis that the placebo group will have reduced changes in cortical grey matter, subcortical structures, volumes or thickness compared to the antipsychotic group. Secondary hypotheses are around the placebo group having less cardiovascular risk at 3 and 6 month assessments, that there'll be no worse on symptoms at 6 months, that it will be feasible, acceptable and safe to conduct the study, and to delay antipsychotic for up to 6 months in the first episode group. Also that the placebo group will be no worse on SOFAS at later time points at 12 and 24 months where there'll be follow-up assessments, and the placebo group will be no worse on neurocognitive functioning at 6, 12 and 24 months. So the studies are non-inferiority design with the primary outcome of SOFAS at the 6 month assessment point. So we're saying that the placebo group who receive the intensive psychosocial treatment, as do the group who get the antipsychotic, will be no less effective. That treatment combination will be no less effective than those that get the active medication. The power calculations specified a sample of 60, but because we have very strict safety criteria that Brian's going to talk about, it means that a proportion of the sample discontinue the study before the 6 month time point, and so we're collecting a bigger sample of actually 95. So it's a triple blind RCT, so the participants, the clinicians and the research assistants are blind to treatment allocation. It's random assignment to either medication with the intensive psychosocial treatment or placebo with the intensive psychosocial treatment on a 1-to-1 ratio. We've got a stratified randomisation design to control for gender and DUP, which are known to be associated with outcome in first episode psychosis. And we use DUP as a 3-level factor, less than 1 month, 1 to 3 months, 3 to 6 months. We don't take anyone into the study who has a DUP of longer than 6 months because we felt that that was unnecessarily prolonging DUP. We thought it was better to work with people with DUP less than 6 months. So the active medication is risperidone, which is over-encapsulated and packaged to be identical to the placebo. And the dose is escalated by taking extra tablets. So in fact, some people will be getting escalated doses of placebo. So the inclusion criteria, because it was very important to us that we conduct this study safely, and it was also a requirement of our ethics committee when we started the study. So our inclusion criteria are the ability to give informed consent, to have, as I said, DUP of less than 6 months, to be low on suicidality, using the BPRS suicidality subscale to assess that, and that's kind of equivalent to no more than occasional suicidal thoughts with no plan or intent. To also be low on aggressiveness, so low on hostility, less than 5 on the BPRS hostility scale, which means they can be angry or yelled, but has not threatened people or thrown objects. We require that they're currently living in stable housing, in regular contact with people who support the young person's participation in the study, and to have had a limited prior exposure to antipsychotic medication before coming into the trial. So that's operationalised as 7 days, treatment with antipsychotic, or less than a total of 1750 fluorochromazine equivalents. The intensive psychosocial intervention is comprehensive formulation-driven cognitive behavioural case management, called CBCM, which is, I guess, an intervention that's been developed over the years at EPIC and Origin. There's also a version of it is applied in the UHR work. It encompasses assertive engagement, so people will go out and find young people who aren't coming in, problem solving and advocacy in the case management role, as well as cognitive behaviour therapy aimed at symptom and stress reduction, adaptation to illness, adaptation to having had an episode of psychosis, and treatment of any secondary morbidity that might be present, anxiety, depression, substance abuse. The clinicians who are regular EPIC case managers who then volunteer to be part of the stages study, they receive individual and group supervision, and they complete a post-session checklist to record what work is gone in the session. There's close monitoring of the participants in the study. The case managers rate the inclusion criteria in terms of their suicidality and risk and severity of the psychotic symptoms every week, and that information determines whether someone stays in the study. Brian will talk a bit more about that. We also have frequent appointments, so up to 2 appointments in the early phases that can taper off. The clients have individual crisis plans worked out, and because the study happens within Origin Youth Health, there is a 24-hour crisis response available from our YAP team. The intervention also involves family support and education, and as I said, at least weekly sessions initially. Okay, measures. So we're taking measures of diagnosis and history. So we get SCID 1 diagnosis, SCID 2 diagnosis, pre-morbid adjustment scale, the childhood trauma questionnaire, general trauma questions, psychopathology and functioning, the negative symptom scale, CGI, Hamilton anxiety and depression, a measure of substance use, SOFAS obviously, to assess functioning, the quality of life scale, and the World Health Organization quality of life. There's a neuropsych battery that you can see there, the RAT4 tests from the WASTE-3, the Stroop test, and then a test of verbal learning and a test of verbal fluency. And we take measures of physical health parameters as well, height, weight, waist, blood. UKU is a side effects scale that is assessed regularly, 6 weeks and 3 months, and also MRI scans. So we have MRI scans at baseline, at 3 months and 12 months. So that to help us look at the question of the impact of medication on brain structure. Okay, so I did pull out some very interim results from a few weeks ago when we had 83 in the study. As I said, I'm pleased to say we've got 88 now. So our group is looking like this. They have a mean age of 18, a range of 15 to 24. They're slightly more females than males, and they're mostly Caucasian with a small percentage of Asian, African and Aboriginal. In terms of what their occupation is, the highest group are secondary school students, followed by unemployed, then full-time employed, in tertiary education, employed part-time or having a combined work and study situation. In In terms of diagnosis, so psychotic diagnosis of those that are recruited into the study, the highest group are mood disorders with psychosis at 30%. We have 22% with schizophreniform disorder, 21% with psychosis NOS, 14% with substance-induced psychosis, 5% who received a SCID diagnosis of schizophrenia, 5% delusional disorder, and then 2% schizoaffective and brief psychotic disorder. In terms of comorbid or other Axis 1 diagnoses, and some participants have more than one, we've got more than half of our sample with an anxiety disorder, 40% with a mood disorder. This is in addition to the psychotic diagnosis, obviously. 70% substance dependence, 8% substance abuse, 5% eating disorder, and 2% somatoform disorder. The personality disorder diagnoses were very interesting to see because there's a perception among the clinicians that lots of people have personality disorders, but not as many as perhaps people would have predicted. So the biggest group don't have a full threshold Axis 2 diagnosis. And note that we also have been unable to assess 23% of the sample because this assessment is done some way down the track, and some people we weren't able to complete that with. But we have 9% with a borderline personality disorder, 9% avoidant. They're the biggest groups, and a smattering of other personality disorder diagnoses. In terms of psychopathology, we have a mean of 58 on the BPRS total score, which is a pretty significantly unwell score, and also a high score on the psychotic subscale of the BPRS. The Hamilton anxiety and Hamilton depression, they're moderately, suggest a moderately unwell group. A moderate level also of negative symptoms on the SANS. It's quite a high QLS score, so I think talking to the fact that these are people with a short DUP, so they have been unwell for not terribly long and their quality of life is still reasonably high. But the SOFAS of 55 is a reasonably disabled group. So, in conclusion, we've recruited 88 participants so far and we're finishing at the end of the year, and certainly looking forward to being able to report more completely on the results. That means that we'll be finished with our 6 months. I don't think I said the intervention goes for 6 months, and then people are followed up at 1 year and 2 years after that. But by the middle of next year, we'll have finished the intervention phase, and I think we can start to report more fully. I think the study will provide rich data on the impact of early treatment with antipsychotic medication in first episode psychosis and the impact of increased DUP that we've assigned. Provide a better understanding of when antipsychotic treatment can be delayed in first episode psychosis. And as I said, the next paper by Brian is going to talk about the retention of young people in this study and some of the safety data. Thank you.
Very interesting and high value study, I think. I want to know what was the response like when you explained the intensive program to the participant. I mean, were they happy to hear that kind of program instead of medication, or whether they were concerned,
So the intensive psychosocial treatment is treatment as usual within the EPIC program. So it wasn't a matter of saying you have to opt for this or that. What people were signing up for is being randomized to receive active medication or placebo. So that's still a very important question, but it's different to whether they were signing up to the intensive psychosocial treatment. Because in fact, that's what everyone gets coming into EPIC. The additional part, I guess, to this study is the close monitoring. So people are followed up. They're not allowed to fall off they're not allowed to disappear. So they're followed up a little bit more assertively, and they're rated more systematically if they're in the stage of study. But the psychosocial treatment is really treatment as usual at EPIC.
Just one more simple. What would you do when the participant in the intensive program, their symptom got aggravated? Do you stop the study design? What if their symptom aggravated? Yeah.
So if their symptoms get worse, that's what Brian's going to talk about in the next paper. Can I leave it for him?
Yeah, so Ingrid Melle, Norway. I have a question that's more, it's partly along the lines, a bit of a conceptual question, because when you presented it, it was a bit unclear to me. If you were thinking about this as randomizing people to an intensive psychosocial treatment that actually might have influence on the course of the disorder. So you were, in a way, saying we have an active treatment that might have an influence, and we don't know if adding on antipsychotic medication is necessary or not, or if you are really randomizing to something you don't think is an active treatment. It was related to, you say, you're prolonging duration of untreated psychosis. So if you think that your other arm has something that might influence it, you might not actually prolong the duration of the untreated psychosis. And the way you were talking about it was unclear to me what you thought about your other arm, because I think that's essential for understanding the results. Are you putting people on non-active treatment, or are you or are those who are receiving antipsychotic treatment receiving something that might be active?
Like you wanted to say something like that. So I believe that the psychological treatment, the intensive psychosocial treatment, is a valid treatment, and that young people can recover. I think that what we're looking for is trying to get a better idea about which ones and how to select those that can be delayed from having medication. Does that answer the question?
If I could just add something, maybe. I think there were three things in this study that we were trying to test. One was the idea, and people used to say this was unethical to do this, but we found a way to sort of do it safely, I think, and to test the idea that if you experimentally lengthen the DUP, which the TIP study obviously was quasi-experimental, but this is experimentally lengthening the DUP if you're talking about treatment with antipsychotics. And that will test that. But the thing is, even though there's 88 patients in the study, it took 8 years to recruit them, and they're a very small percentage of the people that come into our service, and all the rest were excluded because of too much acuity or other safety issues. So it's not going to be very generalizable, I don't think. It's my personal view. The other things were prompted by the Andreasen sort of correlational study, which suggested that antipsychotics might be actually causing some of the brain changes over time. Now that study could not sort out cause and effect, but here with the brain imaging part, we will be able to see what patients not receiving antipsychotics in these early stages, what happens to their brain versus those that do receive them. And I guess the third one is to actually define the size of the group that can be safely treated with antipsychotics, as well as the psychosocial aspect that helps. Thank you, Shona. Yeah. Okay, so that's quite a good segue to introduce Dr. Brian O'Donoghue, who's really been playing a very key role in this study for the last few years and has helped us to recruit safely the number of patients that we have. So we're very grateful to Brian. He's going to talk about this issue of safety and other medical issues.
Well, while I'm waiting for here we are. All right, this is an outline of the talk. And essentially, I might just add a little bit to the background and talk a little bit also about the rationale. Because essentially, if we look at the clinical guidelines for early psychosis, up until recently, the vast majority of this essentially straight away you have to start antipsychotic medication. But we know this doesn't actually reflect what a number of clinicians experience quite frequently, which is that people who've got decisional capacity and can make an informed decision actually decline to take antipsychotic medication and express a wish to try without. And obviously, you need to have flexibility, and also it's very important that clients have the right to make decisions about their treatment. But essentially, if clinicians went with this, they're working outside of clinical guidelines. So one of the aims of essentially the status studies, as we've heard already, is that to identify if it is safe and possible to do that, to either find a subgroup who can recover without the use of antipsychotic medication, or whether you can safely delay the commencement of medication. That's essentially the rationale and of the study. And also, this has actually been recently reflected in the NICE clinical guidelines, which this guideline does actually make provision for if someone with a first episode psychosis decides not to take medication. And what the NICE guidelines actually say is that you advise a person that if they want to try psychological intervention alone, you inform them that they're more effective in conjunction with antipsychotic medication. But if they continue to say they don't want to take medication, then you can offer them a family intervention and CBT, and also you agree a time limit, and they recommend 1 month or less, where you review the situation and you closely monitor them. Now, these guidelines came out in 2014, and that's after the status study was designed. But that actually essentially is what we're looking at. Is it safe to actually do that? So the NICE clinical guidelines actually have made this statement, actually in the absence of evidence, but for clinical need. And with the status study, we'll be able to answer these questions. We've already heard the background as well, just from Sean. This is Sean's paper, and it's continuing research that outlines the background, and also Tony Morrison's paper as well that came out recently in Lancet, but I will talk about that shortly. So in this talk, we talked about the rationale and why the study is important, and that's one thing, but actually getting up and running and doing this trial in a safe manner is another thing, and also convincing real ethics committees that you can to do this study. So I'm going to talk about the safety measures that we had to put in to actually conduct this study in a safe manner. Talk about the consent procedure, the discontinued criteria, safety monitoring, also possibly unblinding. And then I'm going to talk about the proportion of participants for whom it was required to discontinue study medication, the reasons for discontinuation, also at the time of discontinuation, and also talk about serious adverse events which we monitored throughout the intervention period. This is just a brief outline of actually how the service works at Origin Youth Health, and we receive referrals from it's open referral that comes through this kind of centralised triage. We receive referrals from GPs, mental health professionals, emergency departments. The reason I just put this up, I won't dwell on it, but essentially is when someone is diagnosed with a first episode psychosis, they get referred to the early psychosis clinic. And if the participant fulfills the criteria, the eligibility criteria that Sean has described, first episode can make informed consent, DUP less than 6 months, not high risk to self or others, then they're offered the study. But we have to do it in a very short window to offer some of the trial, because we don't want them in limbo, essentially, either not on medication or not in the study for a long period of time. So actually we really tried to narrow that down to just a few days, but also having it within that people have obviously sufficient time to make a decision about it. Also, we got referrals directly in, but also young people transition to a first episode psychosis from within Origin, so we take referrals from the PACE clinic, but also from the clinic with personality disorders. Clients within that service also transition to a full first episode of psychosis. Just to talk for a moment about the consent procedure, because this is an important part, because what we really need to make sure that everyone can make an informed consent about it, and sufficient information. So just going back to that time, when people were screened for eligibility, and they seem to be potentially eligible for the study, everyone that comes through the service also has a medical review, and that was partly in terms of looking at diagnosis, but also it was very clearly assessed whether the person had decision capacity or not, and if they didn't, then they weren't obviously considered for the study. And also then at that time they're informed of the study and provided with written information. Typically we met with family members as well as part of the study criteria. You need to have sufficient support around you as well. But we did include people under the age of 18, and in those cases that family members provided consent on behalf of the young person, and also given adequate time to decide as well and ask questions. We also had very strict study medication discontinuation criteria, and these in some ways reflect the entry criteria. So in terms of suicide risk, presenting at high risk of suicide measured at BPRS, a score of 5 or greater. A risk to others, it also measured the BPRS, a score of 5. And I'll show you what those correlate, those numbers kind of correlate to. And a decrease in functioning, a drop in functioning, but also any deterioration in mental state. The question that's there, that was built in that we would stop the study medication. And then also a lack of improvement in psychotic symptoms at the 12-week mark was also built into the study protocol. So if someone hadn't improved after 12 weeks, then we offer them open label medication. And also, obviously, at any time, the participant decided they didn't want to take part, or if the clinician did as well, then we stopped the study medication. But it's important to say that if people were discontinued from the study medication, that didn't mean that they were withdrawn from the study. They continued to receive the intensive psychosocial intervention for that period of 6 months, and we still did all of the regular follow-up points as well. So they were still included in the study, and we still did all the follow-up. Just to look at what that correlates to. And I think Sean already mentioned it but a BPRS score of 5, which meant that you were kind of removed from the study medication, correlated to fancy suicide by various methods, have considered making an attempt with a specific time or plan, or an impulsive suicide attempt using non-lethal methods or in full view of a potential person that helped them. So you can see there that we have to put in criteria, but actually that's it's moderately severe, and it's not a clear suicide attempt. Because of the criteria, so we have to make sure we have a low threshold for it. But also, if we look at the risk to other people, a score of 5 has threatened, slammed things, or thrown things that will be sustained for a few days. But actually, and then so that is much any physical harm to others, and those any threatening harm. So you can see there we have to set the bar very, very low in terms of when we remove people from the study doing harm to others. And this dates back to get the study through ethics and demonstrate that we can do this in a safe manner. So we also had to look for safety monitoring and look for any adverse events. And we have a sponsors operation in Origin who oversees studies, and they looked at oversight study monitoring and also conducted internal audits of the study on a regular basis. And just to mention, I suppose, what an adverse event is essentially any undesirable medical condition that's occurring from the time of signing the informed consent through to the intervention period. And it may or may not be deemed to be related to study medication, but if it happens, you have to report it. This can relate from anything from a mild gastric illness to headache. We report everything. So in any study, you get hundreds of adverse events. What I'm going to talk about more is actually the serious adverse events, which essentially have to be reported straight away and are serious events in any study. And they can be defined in the following criteria: results in death, is immediately life-threatening, requires inpatient hospitalization or prolonging of the current admission, and results in persistent or significant disability or capacity. It's a congenital abnormality or birth defect, and also that medical event that may jeopardize the patient or may require medical intervention. I'll talk about the serious adverse events, but the criteria for the inpatient hospitalization is the one that mainly applies to the study. And also we had to make sure that we had a process for unblinding in case of emergency. So what so for example, if someone has taken an overdose and is in hospital with study medication, or if there's a medical need to know whether they received antipsychotic medication or placebo, we had to be able to find this information urgently. So essentially, we had a doctor on call at all times. We had to have alerts on people's medical records that our acute team could access, and also we had a pharmacist on call 24/7 in case of emergency. So there's lots of planning that has to go around to make sure we do this safely. So I'll just talk about those what happened. Talk about the safety measures in the study. And as Sean mentioned, we have 88 people in now. I'm going to give results for 84 participants, and that was up until September this year. Recruitment will cease in December of this year. We haven't got the full contour diagram, but what I did want to say is that when you look at the eligibility criteria, obviously that screens out, that excludes a large number of people. So it is a subgroup, very select subgroup, who are eligible for the study. And I agree with the comment made earlier that naturalistic cohort studies can give very valuable information because of all of the criteria we have. It means that we have a very kind of select group. But I just put this result up because it's kind of interesting about the acceptability of the study. So of a group of people, 50 people who were eligible to be studied and were approached and informed about the study, that actually 70% of people actually consented. So this demonstrates that we had a very high consent rate, a very acceptable study, and lots of the young people who consented were interested in the questions but also reassured that we had safety protocols and measures in place if it wasn't going well. So looking at the discontinuation, the number of people who had to be discontinued. So out of 74, so at the time of that with the 84, 10 were still in the first 6 months of the study. So of the 74, 24 people completed the 6-month intervention. So that's 32% completed the 6-month intervention. And 5 out of 10 of those who are currently in it have been discontinued from the study medication. We also had a situation where 9 out of 84 never commenced taking the study medication. That's for multiple reasons. One is that people can change their mind after providing consent and do the start, or else also at times we've had where situations have deteriorated after they signed the consent, or we get new information relating to risk, and it means people aren't starting medication. So what we found is that 56% of participants were discontinued from study medication within the 6-month intervention period. I'm going to talk about now then the reasons for discontinuation. So the biggest reason was the increase in risk, and that was grouped together, but and that related to 10 participants and nearly 12%. And risk itself was the majority of those related to 6 participants. Also, participant request was another factor as well. Didn't give a specific reason, but they just said that they wanted to withdraw from the study, and that represented 10%. A lack of improvement, the previous question there, that related to 10% and 8 participants, and the worsening of symptoms for 8% of people as well. Side effects were also a reason why people discontinued. 3, disengagement, and people moving out of area. If they moved out of our catchment area, we weren't able to provide intervention, so we hadn't been obliged to discontinue it. So essentially, there's a large number of reasons. Each of them maybe numbers 10 or less, but cumulatively it means that we've had that significant number of people who have been discontinued from study medication. And if we look at the time to the discontinuation, there's differences within the groups, and for an increase in risk, people were withdrawn after an average of 6 weeks. So it meant that the risk that happened very, very quickly within the kind of 6-week period. While lack of improvement, that was at the 11-12 week mark, which was stated in our protocol, people hadn't improved. Participant repression happened about the 10-week mark, side effects 11 and 12 weeks, and then worsening symptoms happened again. People were withdrawn early at the 8 or 9 week mark as well. So essentially, for both increasing risk or worsening symptoms, people were withdrawn relatively early, so it meant that they didn't remain in the study for a long period of time if they either increase in risk or worsen symptoms. Talking about the adverse events, so we had 19 serious adverse events which were related to 16 clients during the intervention period over the course of the trial. And if we look at the breakdown of those, and I'll also say is that the first 4 in those criteria, they all resulted in hospitalization, and that's the reason why they were classified as serious adverse events. So the first one is deterioration of mental state related to 9 participants. 6 of those had already been discontinued, and they were admitted to hospital, and then there was a further 3 who were discontinued at that time. Also an increase in suicide risk related to 4, and 1 had already been discontinued, and 3 were discontinued as a result of that, and they were also admitted to hospital. An increase in suicide risk, actually 2 overdoses occurred, and they were participants who had already been discontinued from the study medication. That kind of reflects that anyone who looked like the risk was increasing, we withdrew them pretty much immediately from the study medication. And then there was 2 cases of medical symptoms where actually people were admitted to hospital for medical reasons, but still get reported as a serious adverse event, but that wasn't deemed to be related to the study medication. And in 2 cases, because we do MRI scans, we actually picked up 2 abnormal findings. I think if I recollect correctly, both of them were connected to the pituitary gland, and 1 person had already been discontinued, but 1 person remained on study medication because it was felt it was related, and both cases were referred to neurosurgery. So in summary, what we've seen is that in the small number of people who were eligible for the study, we found a high consent rate for the subgroup who were eligible. but also a high rate of discontinuation of the study medication, and that's for a range of reasons and safety measures. And in cases of increased risk or worsening symptoms, discontinuation occurred very early, and we had 19 serious adverse events, and 17 of those were due to hospitalization. And I suppose just to kind of reflect on those in the discussion, the first thing to say is the rationale for the study and the aim of the findings is very solid, but actually these are very complex and challenging studies to actually undertake. A very, very strong emphasis on safety. And in fact, we had such strict criteria in the protocol meant we had no flexibility for deviation, and even if it was the client's preference. So it's slightly ironic that this study is about promoting client choice and consumer choice, but in fact, once we deviated from the protocol, we actually had no choice, we had to withdraw from the protocol. And also, there's cases where the risk was not always related to psychosis, that people had achieved symptom remission in terms of psychosis, but actually they still, if their risks escalated for other reasons, so as shown and represented there, with high comorbidity within the group, that we were still obliged to actually withdraw and discontinue from the study medication. And also you have to think that this is in the backdrop of early psychosis, when this is the first presentation of mental health services. As we know, clinically, there's actually a high level of switching that occurs in early psychosis. It usually takes 2 or 3 trials for antipsychotic medication before one is found that's suitable in terms of effectiveness and also tolerable side effects. And also in the backdrop that 16% or higher discontinue study medication as well. So all those add to the complexity of it. So as mentioned, due to complete improvement at the end of this month, this year, the last 2-year follow-up will be December 2018, and so it will be a while yet before we full results of the study, which is IEPA 2020. So thank you for your attention.
Thanks. A general comment about the issue of treating first psychosis without antipsychotic medication, because from a public health perspective, in my opinion, the priority is a different priority. Most of our patients, first episode psychotic patients, receive a lot of unnecessary drugs. Lot of patients receive antipsychotic polytherapy, lot of patients receive benzodiazepines, lot of patients receive mood stabilizers, lot of patients receive antidepressants, and in most cases they don't need it. So from a public health perspective, I think that the real battle should be aimed at making sure that patients receive a rational monotherapy with just one antipsychotic medication at the lowest possible dose and for the shortest possible period of time. I don't think that now there is the real possibility to start a new action in the services to convince people to not treat some patients with antipsychotics and leave the large majority of other patients taking a lot of drugs.
Well, I think you've identified another huge challenge, which I'd agree with the polypharmacy is a major problem. I suppose I think that's a separate, it's a very valid and separate issue. It's another challenge that we face. But in fact, you think about it, it's one of the philosophies behind the study is getting clinicians and services thinking, well, actually, medication may not always be indicated. And we are talking about a very small subgroup, but it might be more of a mindset. So I do think there is a place for this study in actually addressing those issues, because what you might see then is actually services being able to advocate for the full psychological and psychosocial input packages to demonstrate that these are effective treatments, it's not just medication. So possibly a net benefit from these addressing polypharmacy, because it's a effective philosophy behind it and having the data.
I'd like to know the usual discontinuation rate of epiquine. If discontinuation rate of this trial is higher than usual rate, do you think that explanation of study design with flashbomb to clients may influence the higher discontinuation rate?
Just to clarify, you're asking, is the discontinuation higher than, say, regular clients not in studies? The answer is we don't know. We're actually going to be looking at that as a cohort study. It's coming, but it's actually not just by discontinuation, but switching. I mean, it's very, very frequent for people to be switched medication. But in this study, we didn't have the option of switching. We just had to discontinue them. So I suspect because of the criteria that we had, it probably is higher because we had no flexibility. You know, once the exclusion, once the discontinuation criteria was met, we were essentially obliged to do it. Otherwise, we'd be operating outside the safety measures we put in place to make sure we could do it safely. So I suspect it probably is higher because of the protocol.
Two questions. Was the blind broken for the SAE?
Yeah, no, we haven't actually unblinded people, participants in the last 5-6 years. Talking to psychiatrists who worked on the trial previously, I think they did have things about 2 cases of being unblinded. But actually, we go to great efforts to keep them blinded. So when we discontinue the study medication, we actually just taper it down and then titrate up in conjunction in discussion with the participant a new medication. We tended to do that. We also had a lower threshold to admit people to hospital. We do a lot of community service, but actually in the trial, because we needed to taper the study medication quickly, we often admit people to hospital to do it. But we kept, so they've essentially continued to be blinded. Yeah.
Once the study's completed and you have the results, though, would you go back and look at those, would you break the blind on those patients?
Yeah, we can do. We'll obviously at that point that we all blinded. Yeah. Anecdotally, the psychiatrist who I spoke to about that, when they have blind people, they're on that medication.
Second question, in terms of the assessment of capacity, you'd indicated that was a medical doctor. Was that a psychiatrist or a separate physician who did to assess that capacity?
It was either a senior registrar or a psychiatrist that did it, that assessed capacity.
So always a psychiatrist, either in training or a
exactly.
trained psychiatrist.
Yeah.
Okay,
It's a very, very impressive study, and I certainly look forward to seeing the results. I might have hoped for 2018, but we'll settle for 2020. So the question that I have is, assuming you demonstrate non-inferiority between the low dose of risperidone and placebo, what would the clinical recommendation be in going forward? Because obviously there's variability, and one can guess that some of the patients where there's increased risk are on drugs, some are on placebo, so there's some variability there. How would you, what will you expect people to do going forward, assuming your primary hypothesis regarding non-inferiority on social functioning is correct, is sustained, and of course there are going to be differences in other outcomes, so that they won't always be consistent.
So in some ways, what you're asking what the clinical implications would be, and currently where I practice in EPIC in Melbourne, we actually have a proportion of people who aren't on antipsychotic medication in the clinic. So there's people with a first episode of psychosis who choose not to take medication, and we facilitate that, and we continue to offer them psychosocial interventions. So in fact, now that I don't know if that happens everywhere in the world. So I don't think it does. So essentially, it might make it more acceptable for that to happen elsewhere. But also, what it does is it gives clinicians some ground to actually do that practice, because at the moment, part of the NICE guidance, they're actually operating outside of clinical practice guidelines, which is so I think that's one thing, is actually giving some perhaps reassurance. But also, it means that you can have more quality informed discussions with people with first episode of psychosis to say, look, this is the outcome. You see from Philippe's study there, you can say, well, this number of people recovered, higher number recovered taking medication. But if you don't want to take medication, this is your chances. These are the stats. This is what you're facing, and the person themselves can make that informed decision. So that's what I would envisage coming from that. It'll allow, in some ways, clinicians to facilitate clients making informed decisions and updating the clinical guidelines. And we may have some provisional results 2018, because I think we might look at the 6-month data.
Okay, well, I might draw the
symposium to a close, but to thank the speakers and also thank the audience for very interesting questions and discussions. Thank you.